Yes, this is it's a very timely question nowadays, whether you really need a transplant in Philadelphia positive, which was absolutely essential in the past. The issue is, A, that we have to keep in mind that many patients are elderly. In fact, 1 out of 2, more or less, of the less young population, let's say over the age of 50, 55, are Philadelphia positive. And transplant was the only way of saving these patients in the past, so it makes it more difficult. Now, with the TKIs, this has certainly changed, and we are questioning whether we still need a transplant. Now, why are we doing that? Because TKIs have impacted dramatically, and in my talk I gave the data with the different TKIs. And in addition to that, there's been an added chapter of immunotherapy. So in our last published study, the so-called D-ALBA, a study which was for frontline patients with Philadelphia positive, all adults 18 years up with no upper age limit. All these patients received the TKI Dasatinib plus steroids, and then they were consolidated with Blinatumomab, this bispecific monoclonal antibody. That is a form of immunotherapy because it targets leukemia B cells, but it activates the host immune system targeting the T cells of the patient. Now, the first paper was published in New England Journal of Medicine in October 2020, and the follow-up was published, was online in December, last December, in the journal Clinical Oncology. And this was important because it showed the follow-up, long-term follow-up of these patients. The follow-up is 53 months, so that's over 4 years. And the good point is that we had survival curves that range between 75 and 80% at over 4 years, which is obviously very good news. And I said this morning at my talk that half of these patients did not receive systemic chemotherapy nor transplant, and they're doing well at more than 4 years follow-up. And why are they doing well? Probably because these have been very closely monitored for MRD by molecular testing, all centrally done at our center in Rome, by quantum PCR. And almost all patients who were MRD negative, sustained MRD negative, were not transplanted. And these patients have been doing fine. 96% are still in remission without having ever received systemic chemo transplant. Patients who were transplanted were largely MRD positive, so MRD becomes a discriminant between transplant and transplant now. I gave more data, and I said at the end of the day that the study that's ongoing now in Italy, the GIMEMA, which is the first randomized study, phase 3, ever done for Philadelphia positive, we're randomizing Ponatinib plus Blina versus Imatinib and chemotherapy. The product is doing very well. We hope to finish enrollment overall 236 patients by the end of this year, beginning of next year. That study will be tailored exactly to define how many patients can be spared chemo and transplant. The data we have now indicate that this is possible in a proportion of patients, but nobody knows how many these are because no study has been tailored to answer this question. So this is why we believe that a good proportion of patients will be managed only with a TKI plus immunotherapy without having to get systemic chemo and transplant. Yeah, this I already alluded to. This was the recently published paper indicating long-term overall disease-free and event-free survival. So what I can add is that this was very rewarding, obviously, because many studies, you see that part of the first report, the early findings are very positive, then follow-up becomes longer, the results get, let's say, less exciting. These have held over 4+ years, so this is very good news. What I can add is that one issue that we'd already noted in the first report is the issue of the CNS localization, of the central nervous system. We had reported that we were seeing patients in a follow-up study. We've seen so far only 9 relapses, but 4 or 5, because one was partially had the CNS localization. So that is something we have to be very careful at. I don't think it's more than the past. It's probably that we've seen less hematological relapse, so this stands out. So based on these findings in the current study I mentioned earlier, the one with randomizing, the experimental with Ponatinib and Blina, we've increased the CNS prophylaxis, increased to more intrathecal and with a triple combination of drugs. So far we haven't seen any CNS localization, but it's early days. So that's where we stand, and again, the end of the study should give us further information also on the issue of the CNS localization.